to introduce myself to those who don't know me?
No, sir. No, sir. I have to introduce you, sir. Give me that pleasure, sir.
There's no
I
need,
have to
Mr.
introduce you, sir.
Why do you want to waste time there?
No. It's well worth it, sir. It's well worth it, sir.
Okay, as you choose.
Yes, sir. My dear colleagues, good morning and welcome you to this webinar of case discussion sessions. It is my pleasure to introduce Professor Zahir, who was my teacher. Professor Zahir was an honorary professor of neurology at the Institute of Neurology for close to 20 years. And earlier, he was the professor of neurology at Government Royapeta Hospital. He was the head of the 4th neurology unit at the Institute of Neurology, being an honorary professor of neurology. He was deeply interested in clinical neurophysiology, and apart from teaching and demonstrating electromyography and evoked potentials to us, the postgraduates, he conducted workshops on ENMG, electroneuromyography, and evoked potentials regularly in the 80s, and was perhaps the first such workshop was held in the Institute of Neurology in the country itself, drawing postgraduates and young neurologists from all over the country. He also established the clinical neurophysiology department at Apollo Hospital and was its director. Professor Zahir took theory classes as well for us, the DM postgraduates, the only one to do so then at that period of time, and his classes on eye movements and nystagmus were hugely popular and still remembered. As far as I can tell, he was the first to show keen interest in movement disorders. To me, movement disorders has grown exponentially in India now. But to me, he was the father, as far as I know, because he was the one who introduced the concept of movement disorders, and he was deeply interested in chorea and myoclonus in the late 70s, and also used to formulate his own treatment. Example, for chorea, we tried, in fact, at the Institute, INH as a medication for suppressing chorea. And this was in a period when movement disorders was in its nascent stage, even in the West. He also showed keen interest in myasthenia gravis and Guillain-Barré syndrome and formulated his own protocol of managing myasthenic crisis. This was all before the advent of IVIG, and also when plex or plasma exchange was not widely available or practiced at that point of time. He introduced the American mode of teaching for us, with discussion between as the teaching would be as a discussion between a junior and a senior or a super senior colleague, rather than between a teacher and the thought. That sort of relationship was there. And he always inculcated more interaction and promoting questioning. In fact, he used to ask us, the postgraduates, to challenge him on whatever he was saying. Please challenge me, question me. Don't accept whatever I am saying. You question me. This was how he used to teach us. And in those days, when we did not have access to recent literature, apart from standard textbooks, he used to provide the course material of the annual meeting of the American Academy of Neurology, which we would religiously photocopy without his knowledge. And this was carried out by several batches of postgraduates till, I think, till 1988. From 1981 till 1988, we were just photocopying his annual course material, which he provided. In short, that is Professor Zahir. And I have given a bit of a longer introduction today because he has not appeared frequently in our forum, and many of you may not know about him. Now, Professor Zahir, sir, you may proceed. You may conduct the proceedings as you wish. And thank you very much for accepting, sir.
Good morning. Good morning, Dr. G.A. Very nice for you. Very nice for me, particularly to see you on the forum. We have Saravanan.
Sir, morning, sir.
Hello.
Morning, sir. Morning, sir.
Morning.
Sir.
The HOD
Morning, sir.
And Chief of Neurology at Trinity Medical College Hospital. And he is going to be talking on management issues in a patient with MS. I give the forum to Dr. Saravanan now. You can start, Dr. Saravanan.
Thank you, sir. Thank you very much, sir. Sir, my screen visible, sir? Sir, my screen is visible.
Yes.
Your screen has become visible, you are not visible.
I may not be visible, sir.
But that's fine, that's okay. So long the clinical details are visible.
Sir, today I'm going to present about a case of a college student, 20 years old, who presented with us with a double vision of 10 days duration. An acute onset, it was present on looking towards the right side. The images were separated horizontally. The false image being separated away, that is, it was present away from the real image. And it was associated with the vertigo at the onset and mild unsteadiness at the time of onset. And there was no associated fever, there was no history of vomiting, headache or seizures, and no history of loss of consciousness, and no history of drooping of the eyelids, and no history of fatigability, and no history of weakness of the limbs, bladder and bowel disturbances. And this, it did not have any specific past history, and there was no family history of similar illness also. Examination showed stable vitals, her higher mental functions were normal. Her visual acuity was 6/6 in both eyes. Color vision was normal. Extraocular movements showed right-sided internuclear ophthalmoplegia and gaze evoked nystagmus and looking towards the left side. Horizontal nystagmus, there is no vertical nystagmus, and there was no ptosis. The vertical eye movements were normal. And examination further showed normal size people reacting normally to routine accommodation. There was no RAPD, no relative afferent pupillary defects. The other cranials were normal. The motor system power was normal. There was no weakness. There was no sensory deficit, but there was a difficulty in walking in straight line. But other cerebral signs were not present. Bowel and bladder were normal. She presented with the cerebral signs and we made a diagnosis of a brainstem lesion, posterior buccal lesion, and we did a MRI. Investigations. This is the MRI. We are not able to get the whole picture, but I'm able to show you some of the MRI cards. And this one, the MRI, the right plate, you'll be able to see the hyperintense lesion in the posterior part of the brainstem, close to the fourth vertical.
Speak up, I can't hear you,
Not clear.
not clear.
Get near the mic.
The posterior part of the pons and medulla, there is a this is another MRI cut. The flare sequence. This show the corpus callosum. The T2 images the corpus callosum.
No, you must get to the mic.
Sir,
I can't hear you, young man,
Not clear.
not clear at all.
I'm not audible, sir.
No,
Yeah,
I
better.
would, I saw
I'm not
the,
audible, sir.
pardon me?
Yeah.
Huh?
Yeah,
Better.
I can hear you better, but I want to see, you want to show the MRI now and say what the neuroradiologist thinks about it.
Sir, is it audible now, sir? Am I audible now, sir?
It is
Yes,
very
yes.
audible, but your MRI has gone out of focus.
No, I'll share the screen now, sir. I'll share the screen now.
Okay. Ah,
So this is the MRI, sir.
yes,
This MRI shows a small hyperintense lesion in the posterior aspect of the brainstem.
yes, it is obvious. If you can encroach it, everyone can see it. I can see it.
I can enlarge and see.
Yeah,
Floor-
I can enlarge it
Floor of the fourth ventricle.
Okay,
almost.
sir.
Yeah, அது enlarge பண்ண முடியுமா? அது இது நல்லா இருக்கு. அது போயிடுச்சு.
So this one looks normal, sir.
Pardon me? I
Sir?
think there's a don't you think there's a lesion in the temporal lobes too? Hello?
Okay, sir. Okay.
No, there's some shadows in both temporal lobes. I don't know whether they're artifacts or you think they're lesions.
I'll show you some
The
of
white
some more
blush.
slides, sir.
The white blush in both temporal lobes, medial temporal lobes.
Here the temporal lobe
there
is
you
seen,
can-
sir.
You can see here.
Yes.
You can see here. Yeah.
There's one you can very clearly see. The second also you can see here.
Can you show some cerebellar pictures, please?
Here also temporal lobe is seen, sir.
There's
Yeah,
not so much here.
Not so much
previous-
here. The previous picture, they were next to this one, Ankas, you could see the two shadows there.
Sir, I'll show some more pictures, sir.
Sure,
Okay,
please
Rajat.
do.
Okay.
This is digital one.
Yes.
That seems.
This is the cord, sir.
Spinal cord.
There's nothing in the spine. No, there is something in the spine. Yes, there is, I think. No. Just a minute.
Increase in CSF, such as atrophic cord.
Increase, please increase the width of this picture.
Zahir, you
Yeah.
can expand it on your iPhone.
Oh, okay. No, I don't have an iPhone.
Yeah, I'm looking at it expanded. Seems to be normal to me.
Right.
Sorry, sir, some mistake happened.
Okay, Raja. The lesion is floor of the fourth ventricle.
Sir, this
Certainly,
is the spinal cord cut, sir.
yeah.
Yeah, that's good.
And another spinal cord picture, sir.
There's no isolated lesion in the spinal cord.
No. So this will
Yes, sir.
explain diplopia. 6 now.
The MRI is reported like this, sir.
Right posterior medulla pons extending to the level facial curriculum. These things at least not readable.
Yeah, that's inferior temporal regions. There is.
Okay, take it. Okay.
Little bit on the medial side, I think. Intramedullary. Hello, I can't see the intramedullary. Will you show the spinal cord lesion for me? I can't see that thing. Yeah, that's right. Let me see it.
Expand it, Zahid.
Yeah, I'm going to do that.
iPhone.
Yeah, there is an intramedullary lesion. I can see it. Can you see it, Arjun? Dr. G.I., can you see it?
No, I can't see it. No.
Intramedullary lesion. Very clearly you can see two lesions. Yeah, it's very clear now. One, it continues and again it went downstairs into another lesion. Can you see it?
Yeah, doubtful.
No, but it's very clear now.
சார் அவங்க கம்மி பண்றாங்க இவரு சரவணன் சார் ப்ளஸ்
Sir, MRI, we are convinced that MRI showed a hyperintensity in the posterior as well as the brainstem and in the spinal cord, sir.
Yes, I agree with you.
So now, what is the diagnosis? We consider the diagnostic possibility of a demyelinating disease because of the presence of this hyperintensity lesions. And the three possible diagnoses were: one is multiple sclerosis, second is a neuromyelitis.
I really don't know whether you want to get, NMO in the diagnosis. Possible because of brainstem lesion, but again, that is the area posterima lesion in NMO. and MOG, I don't think you get too many. I mean, it's, involvement of ocular. I mean, third nerve is not very frequent in MOG.
Sir.
no? Basically, I think
Yes, sir.
basically you have what I think you have, what shall we say, coincided with the diagnosis of multiple sclerosis, MS.
Yes, sir.
And,
Yes, sir.
unless you give me justifications for this being an NMO, the only justification
sir.
would be that you do the NMO.
We agree
test.
with you, sir. It is most probably a multiple sclerosis. And we
Most
consider
probably,
like that only.
what other? Tell me other options in this.
No, sir.
Do you have another option? Since
No,
you have
sir.
you have listed NMO and MOG.
We
Sir,
got multiple
Sir,
sclerosis only,
Professor.
sir.
Professor Zaz,
Sir.
sir, can I make a comment, sir?
Yeah.
The spinal cord lesion, which is intramedullary and occupies a short segment lesion, that and the infratentorial lesion, which is in the brainstem, are quite classical of multiple sclerosis, sir.
Yeah, I think so. The whole
but-
process is classical of multiple sclerosis.
Sir, yeah, but as you described, there are lesions in the inferior temporal or medial temporal region.
Medial temporal.
Medial temporal region, and there are no lesions in the corpus callosal region. The classical regions associated with MS, the classical lesions or supratentorial lesions are missing, and there is an medial temporal lesion. I'm not sure whether this medial temporal lesion goes with MS, but the rest are all consistent with multiple sclerosis, though we do not see much of supratentorial lesions.
That doesn't matter. I mean,
Yes, sir.
Yeah, you don't need to see so many supratentorial lesions in MS. But then the problem is with this combination of things. I mean, can you think of anything else? I don't think you can think of NMO at all. No vomiting, nothing. And
Clinically, sir, only clinical feature was from what he presented was an internuclear ophthalmoplegia plus minus right lateral rectus paresis. So in other words, it could have been a 1.5 syndrome.
Yeah, it is 1.5 syndrome. Where is the question? It could have been. It is 1.5 syndrome. Internuclear ophthalmoplegia plus right lateral rectus palsy.
That's all the clinical features. Rest are all
The
radiological.
only way Natarajan, you can think of is if you can get the test. What is this? Protoferrin 4, for
Yes, sir. Aquaporin 4.
Aquaporin 4 positive. If you don't have that positive, I don't think you need to talk about an MS here.
Correct, sir.
And tell me, in how many NMOs will you have an internuclear ophthalmoplegia?
Yes, sir.
And how many NMOs will you have lateral rectus palsy? But internuclear ophthalmoplegia, I don't think very many. And not even MOG. In MOG also, you won't get any ocular findings. Saravanan, proceed. Go ahead.
So investigated the patient that CSF analysis showed proteins 12 milligrams, sugar 110 milligrams, and no cells. So basic investigation: hemoglobin 9 grams, WBC 5,700, platelets 3.99 lakhs, ESR 30 millimeter per hour, urine normal, and thyroid stimulating hormone 2.8 microunits. International units per ml, which is normal range. Then the anti-cardiolipin antibody IgE, IgG, IgM are negative. Antiphospholipid antibody IgG, IgM are negative, and viral meningoencephalitis panel was also negative. We did ANA profile, extracting nuclear antigen, all of them are negative. And the CSF special investigations, the CSF IgG was 38.8 milligrams per liter. The normal is less than 34, and serum IgG 1082 milligram per deciliter, which is within normal range, and CSF oligonucleotide bands are present. The serum oligonucleotide bands are absent. The serum NMO antibody was negative, and the MOG antibody was negative. And before treating the patient, we kept all these things in the diagnosis and treatment. It's an acute onset of disease in a young female.
நம்ம எப்படி டவுன்லோட் பண்ணாது மட்டும்தான் கட்டுக்கிறோம் இப்படின்னு பார்க்கக்கூடாது
Presented with internuclear ophthalmoplegia and cerebellar signs.
எதுக்கு தெரியுமா
There were demyelinating lesions in the spinal cord and brain. CSF showing evidence of intrathecal synthesis of immunoglobulins, and NMO and MOG antibodies are negative, and there is no evidence of infection. With this, we made a clinical diagnosis of multiple sclerosis, first episode as a clinically isolated syndrome. And we treated her with the injection IV glycerol 1 gram per day for 5 days. And patient showed good improvement with the complete resolution of the symptoms. And she is under follow-up for the past 6 months. And for the past 6 months, she has not developed any further episodes. She is okay. She is not on any drugs. Now the question is, she is a female, it's a college-going girl. In fact, she is a medical student as a reproductive age group. And whether to put the patient on disease-modifying drugs or not. If the second attack occurs, suppose we are not putting the patient on disease-modifying drugs, what would be the neurological recovery? This is what we are asking the panel audience and senior professors, sir. Does he need disease-modifying drugs?
Good question. Is somebody else besides myself, Natarajan and Dr. G.A. who want to comment? Then we can comment on that. Hello,
There are several others who can comment, sir.
that's what I'm saying. Why don't they comment? Hello?
Hello, sir.
No.
To comment, Natarajan.
Sir, Justin is there, Vikash is there, Govindraj is
Why
there.
don't they talk?
They or any of them, SNK is there, all of them can comment. Or any of them
Please
can
comment.
comment. Just raise
Which
your hand and
I-
comment, sir, please.
I wish I could see them when they talk, please.
Sir, this is Dr. Vijayan
Yes,
Ah,
Vijay,
tell me.
please.
from Coimbatore. Now, there is no doubt regarding the diagnosis as such, but was a vasculitic panel done, sir? ANA, anti-nuclear antibodies, anti-nuclear cytoplasmic antibodies,
Vijayan,
and the rheumatoid factor, and all these things
Vijayan,
also have to be, sir.
ESRA 30 இருக்குது அது எங்க போகுது vascular dispal ஒண்ணுமே காமிக்காது because ESR is only 30.
Sir, fine,
CRP
sir.
will be much lower.
Vitamin B12, everything. Probably we'll have to do
We can do that.
all that as a routine, as a protocol
Routine,
before
yes.
calling this as an MS. But actually, classically, it has been demonstrated that there are lesions disseminated in space and time also. Though it is a clinically isolated syndrome, since there are spinal cord lesions, infratentorial lesions also. But the only doubt is there are no classical Dawson's fingers or perpendicular corpuscular lesions, and that's my only worry before calling it straightforward illness without doing the other investigations like B12, folate, rheumatoid factor, ANA, anti-DS DNA, ENA profile. All that probably needs to be done before. Okay, accepting that it is an MS in this age group. Now, I think definitely she has to be started on disease-modifying drugs, and the most preferred disease-modifying drug, as far as I am concerned, would be something oral, and probably, as far as I am concerned, would be dimethyl fumarate. Thank you, sir.
Vijay, one correction.
Hello.
Sir,
Sir, one
Sir.
correction.
Hello,
Yes,
Sir.
sir, we are there.
Dr. Bhupati, Dr. Natarajan,
Yes, sir. Vijay.
Professor
one
Natarajan.
correction.
sir,
Professor
I'm listening.
Natarajan.
Speaking, sir. Vijayan, one correction, that
Sir.
is, there is no
Sir.
dissemination in time. It was only monophasic illness, dissemination in space. was
That's it. There's no dissemination in time. It's all one time.
The dissemination in time, sir, can be calculated. I mean, can be assumed as per by the spinal cord lesions. Sir.
No, both were together. Both were
Of course,
both were
clinically-
detected together.
If they are non-contiguous lesions, sir. If they are contiguous lesions, then I agree with you, sir. There cannot be, you cannot call it separate. But if they are non-contiguous lesions, yes, that itself can be taken as an example of dissemination time.
One minute. Non-contiguous lesion is characteristic of multiple sclerosis because they are small segment lesions. If you want
True,
to show that it is dissemination in time, you have to do a contrast enhancement.
Yes, sir.
And
Yes,
show
sir.
that there
Agreed
is
with
a
you, sir.
recent contrast enhancement.
Agreed. If there is a If there are enhancing lesions, yes, I agreed, sir.
எதுல போய் கேட்பாங்க இதுல போய்
No, I said assuming that this is
அதுதான்
definitely a case of MS,
Yeah.
then I would start on disease model.
Correct, sir. Sir, one offer is for dimethyl fumarate, sir. The rest will have to say what would they do. It's an individualistic decision, and what would others do?
Yes, I think I would want everybody else to comment. I mean,
There are a lot of people here who treat multiple sclerosis. They can contribute.
Sir, can I speak, sir?
yes, who is this?
Yes, Vikash, please.
So, sir, very well presented, but due to some technical glitches, I would be highly interested to see in the MRI if there is any leptomeningeal enhancement. Even there is a very short leptomeningeal enhancement, that is something we have to see, because MOGAD disease is one. If you compare MOGAD and NMO, MOGAD is more commonly related, more nearer to MS as compared to NMO. And nerve involvement, especially the head involvement, we have to look more carefully. We have to look more carefully, even though these are seronegative cases. In fact, NMO, 40% NMO negative cases are actually MOGAD. So that is one comment. Another comment I would like to say is that definitely regarding immunomodulation, I have no doubt, because the patient has presented with brainstem lesions, and definitely the patient should be considered for an immunomodulatory therapy, considering the diagnosis of MS at this moment. However, we'd like to repeat the MOG and NMO antibodies again in this patient, and also maybe to do an for the retinal OCT test. So that also can give us some clue, because in the UK series, they have showed that the ophthalmic involvement in MOGAD is more like bilateral, and then it is more on the head kind of a thing. So that can contribute to our more understanding of the case in terms of the diagnosis is concerned. Whereas at this moment, I would definitely like to put the patient on she's a young patient and a very significant brainstem lesion. Definitely immunomodulation should be considered. Whether the immunomodulation, what kind of immunomodulation, whether it is a DMF or PINGO or something else, depend on what will be the future pregnancy status, or what is the plan, whether there is a plan for pregnancy and marriage. So those things are into consideration. So I think there is no right or wrong questions in the choosing as far as the drug is concerned, because that is a decision I would like to take with the patient, rather than a individualistic choice and offering them only one drug.
Sir, there are comments in the chat box. Can you see that, please? Somebody can see that in the chat box and reply.
Hello, Professor Natarajan.
Yes, sir.
Professor Natarajan.
Go ahead, sir. Bhupati sir is on the line. Allegation is waiting. Bhupati sir can go.
Yes, sir. Sir, I have gone through the history as well as the clinical presentation as well as the image findings. Young girl developed a neurological problem. It is the lesions are, mainly the symptoms and signs confined only to the brainstem, but there are lesions, subcortical lesions and brainstem lesions, and also spinal cord lesions. All these, and the presenter told that the patient was given steroid as usual in any of the inflammatory disease of the central nervous system. Patient recovered fully. The image findings are not typical of MS, or not typical of the medullary spinal form of NMO spectrum disorder or MUG. This is an inflammatory disease of the central nervous system. Patient responds to steroid. So why can't it be acute encephalomyelitis? 1. 2. We have to wait. Patient is responding. Give time. And if the patient, and also the lesions are, the spinal cord lesions are very massive. See, in a typical demyelinating disease, MS, multiple sclerosis, the lesion may not be such a long, lengthy lesions. I have seen in my experience, and these lengthy lesions are invariably either it must be an acute encephalomyelitis or it is a form of NMO spectrum disorder. There is no diagnosis, definite diagnosis, except the neurofilament light chain, in the CSF. There is
Yes, sir.
no other definite evidence to say it is a MS. You have to rule out all these MOG as well as NMO spectrum disorder. You have to rule out. If it is negative, you have to repeat it. That is my experience. And this patient has become all right. Right? Can be a acute inflammatory reaction for COVID virus also. There are so many viruses could give us to the picture like this. That is my approach. And if the patient
Bhupati,
develops,
Bhupati,
Yes, sir.
sorry to
Yes, sir.
interject.
yes, sir. Welcome, sir.
Oligoclonal bands are present. Myelin basic protein present. So I don't know that both of these will go with the diagnosis of NMO. Please consider it.
Yes, sir. Yes, sir. Oligoclonal bands are positive means that is. I didn't notice. I'm very sorry. If it is positive, definitely it is MS. But still, we have to wait whether the patient develops the problem again.
What do we wait for, Bhupati?
Saturday, Sunday duty.
Patient has, sir, patient
Dr. Bhupati, what do we wait for?
another attack.
Another attack.
No, another, if she develops problem again, and I will seriously think of starting disease modifying drugs.
I see Dr. G.A. keeping his fingers on his mouth. And I don't know why, but that's okay. Should we wait for another attack?
Sir, this is,
Natarajan?
Sir, can I come in? Can I come in?
Please.
Anybody else wants to
The only
comment?
thing,
Yes,
I
sir.
think
Yes,
only
sir.
one thing what Professor Bhupati was trying to insist emphasis on is that still the diagnosis of multiple sclerosis as such is in doubt in this patient. I think he has a point there. He's emphasizing the point that still we are not very sure that this is a case of multiple sclerosis. That was what when I also started, I said, assuming that this is a case of multiple sclerosis, I would start on disease modifying. So I agree with Professor Bhupati that since still I'm not very sure, convinced that this is definitely a case of multiple sclerosis.
Can I comment, sir?
1 minute.
Yes, sir.
I want-
Allegation, please.
I want the
That is
last
good.
part
Yes,
which he
sir.
said, other, what is that? You don't think this is multiple sclerosis?
I am not, sorry, sir, I am not telling this is not multiple sclerosis.
No, he said something else. I couldn't hear it properly.
There is no definite diagnosis. There's mere finding oligoclonal antibodies are positive. It doesn't mean that it is multiple sclerosis.
Agreed, sir. Agreed.
That's what my point.
Agreed, sir. Agreed.
Sir, allegation is waiting, sir. Professor, allegation, please.
Yes, sir. Sir, according to me, it is a definite case of multiple sclerosis, but it is a clinically isolated syndrome. But MRI-wise, it has got multiple lesions, temporal lobe and the spinal cord. But the immunotherapy medication has not yet been standard practice throughout the world, sir, except the only one trial, there's a topic trial that proved intervention may be appropriate. And that study used only the teriflunomide. If at all, if you want to use the drug, such choice will be the teriflunomide for this case, sir.
Any other commentary?
Can I, sir?
Yes, Natarajan, why not?
Right.
Sir,
First,
brainstem lesions are not very typical of MS in these patients. So that is one thing. And even the MOG disease can present with ADEM because Dr. Bhupati mentioned about ADEM. One of the classical presentation for MOGAD is ADEM. So I think the only thing is that the female sex, it is less common. MOGAD is less common in female patients. So that is one thing I would like to add. But still, it cannot be a seronegative. It can be a seronegative NM also. So I still have doubt of MS in this patient. But as far as treatment is concerned, definitely we need to start because this is a very significant disability, brainstem lesion.
Now, Natarajan, please go ahead.
Sir, Ishwardar sir, you have anything to comment?
ஃபுல் மீல்ஸ் அன்னைக்கு மாதிரி வேண்டி சொல்லுங்க.
Present, sir.
Okay.
Allegation,
Justin,
you
yes,
have
please.
come. Allegation, you want to comment?
No, Justin is waiting, I think.
Okay, Justin, please comment.
Sir, good morning, sir. Sir, I fully agree with Dr. Bhubudi, sir, as he mentioned that lesions are there, but it is not confined. It has involved the brainstem as well as the spinal cord as well as the temporal lobe. So, as of multiple sclerosis, more than 2 segments against for the multiple sclerosis. Oligogonal bands not only present in the MS, it has present in so many conditions as sarcoidosis, SLE, even in Sjogren's disease, even in the meningococcal carcinomatous and other things. So we have to search for the secondary cause for this demyelination rather than branding as a primary demyelination as an MS. Maybe a NMO spectrum disorder because it is centrally involved and floor of the fourth ventricle also involved. We can say that as Vikas told that it may be a seronegative NMO spectrum disorder or a MOGAD.
Yes.
MS putting as an MS is little bit difficult to. Yes, sir.
Sir,
Yes,
Natarajan, sir.
Natarajan, go ahead.
Yes, sir. Sir,
Anybody else
my,
wants to comment?
sir, my diagnosis would be MS, sir. As allegation
okay.
said, I am very clear the diagnosis is MS. I
Sir,
agree. I
yes,
agree the differential. I agree the differential diagnosis would be other demyelinating disorders like MOGAD or NMO spectrum disorder. Now, why is it MS? The patient has only one clinical finding. That is, as Professor Zahir said, 1.5 syndrome. And Professor Zahir raised the question, is 1.5 syndrome a clinical feature of MOGAD, which Vikash will have to answer. The question was, I also don't know the answer. I think it certainly goes in favor of multiple sclerosis. The only point which raises an element of doubt is the medial temporal lesions, which I am not certain. We will have to look at the literature whether it is a feature of MS. Certainly it could be. But as I said, absence of supratentorial lesions or absence of Dawson fingers or absence of optic nerve involvement does not exclude MS. In fact, this is the brainstem spinal cord of MS. And in fact, those who have brainstem lesions comparatively are supposed to have a worse prognosis. That is one thing. Now, the question of MOGAD and NMO, coming to oligoclonal bands are present, of course, in MS, but they can be present in NMO spectrum disorders also, no questions about it. But in both NMO-SD and MOGAD, there will be pleocytosis. There is no pleocytosis. Protein, of course, can be normal in any of these. So that's okay. So absence of pleocytosis, presence of oligoclonal bands, classical presentation, clinical presentation of MS, plus radiological presentations, mostly acceptable infratentorial and spinal cord short segment lesions, MS would be the first diagnosis. Now, the question with regards to other diagnosis, of course, he has done NMO antibody and MOG antibody, and reasonably those have been excluded. Though Vikash's point of double seronegative does happen. Yes, we know that. But you'll have to stick to a diagnosis somewhere. See, you have to give a treatment. So you'll have to decide on the diagnosis. If you say NMO and MOGAD still, you're not going to put them on disease modifying therapy. You're not going to put them on interferon. You're going to put them only on immunosuppressants, and if at all, only azathioprine will be available to them. Now coming to the treatment point of view, she is a girl who is pursuing her postgraduate course, and she is likely to get married and conceive. So the question is, if we are going to put her on a disease modifying therapy, it has to be one which is acceptable for that situation. And there we'll have to consider, of course, now we do not consider a parenteral at all, but we'll have to consider gladiolumab acetate, Copaxone. That's the best drug as far as pregnancy is concerned. If not, if we go for oral, of course, teriflunomide, and next is dimethyl fumarate will come first, or teriflunomide. Now, coming to Bhupati's answer, sir, Professor Zahir sir, personally, I would also like to wait and watch. See, we do not know when the second episode is going to happen. It may not happen for 6 years. It may happen in 1 month. Agreed. But there is no harm in waiting for a second episode. And even if a second episode happens, by and large, the patient is going to respond to methylprednisolone. So in this sort of situation, my take would be, if we need to give a prevention, give IV methylprednisolone 3 grams once in a month or once in 2 months and follow up. That would be my take, sir.
What is the last one I didn't get? What did you say, Natarajan?
Sir, regarding treatment,
Yes, I know that, but last one, I just want the last.
last
You said
one
treat-
was to give intravenous methylprednisolone
Oh, what?
1
10
gram
millimeters.
for
1
3
gram a
days,
day.
once
5
in a
days.
month. Yes, sir. Pulse treatment once in a month or once in 2 months and follow up the patient. If a second episode happens, then we'll have to put it up to her. Because if the person who's a doctor is reluctant, we can't do much in that case. That is the reason why this Saravanan is putting up this patient for discussion. What are we to tell her?
We did not keep quiet in this case. We have to give treatment, as you say, and also do interval scanning, that is imaging studies.
That is
So that
accepted, sir.
it will definitely help us. Are we going in a right path, or the patient is progressive illness? Then we will sort it out. The best disease modifying drug is for this patient. I feel that is interferon will be a good.
Vikash, can you answer on 1.5 syndrome and MOGAD?
Yes,
Vikash?
sir.
Yeah.
Yes, sir. Yes, sir. So I do not have much experience with 1.5 and MOGAD, but it is very common that MOGAD has more common pontine lesions. Number 1 point. Number 2, I agree that the optic neuritis component is much more recurrent bilateral optic neuritis component is much more common with MOGAD, which is not there in this case. And number 3 point, so the pontine lesions can have, and this patient also 1.5, and the nystagmus also was there. So I don't know whether it is the correcting nystagmus or it was a nystagmus because of a different pathway. That has not been clarified in the discussion. But regarding the DMD, the 4th point, regarding the DMD, I would like to choose the disease modifying drug or an immunotherapeutic drug which can cover both MS and NMOSD or a MOGAD. So I would offer the patient, I'm not in very strong favor of an MS in this case because of the brainstem lesions and the spinal involvement, and the optic nerve involvement has not been detailed evaluated. I would like to offer a drug like rituximab to the patient, which will cover both the disease as a single infusion therapy, and it will give a long-term coverage with the immunomodulation. We don't know we cannot presume that the degree of the next attack will be mild, or the degree of the next attack will be that it will be 100% resemblance recovery with the methylprednisolone. That is an assumption which we cannot 100% offer, and especially when a doctor is patient is a doctor and an educated person, this question needs to be addressed. Regarding the pregnancy, that can always be delayed in such cases. We can wait for 1.5 years, see how the disease progresses, and then decide on the marriage can happen, but the pregnancy can still be delayed. So I would not put on single factor on that and avoid an immunomodulatory therapy to this particular patient, taking into consideration the clinical profile of the patient.
Vikas, what is your drug of choice on disease modifying drugs?
Sir, my drug of choice, earlier I was using DMF a lot. I mean, in MS I'm talking about, sir. I was using DMF a lot, but now Fingo also has got a good, it's cheaper, first of all. It's cheaper, and then second, it has got also a good, almost more than 50%. So all these MS trials you have is the percentages somewhere DMD lasts between 30 to 40% or 44%. For DMF, it is around 45%. So for Fingo, it is slightly more than that.
Sir, I have a question to
now. I have
Vikash,
moved
sir.
as a DMD for
I have a
MS.
question to
RR MS, Fingo. Sorry, sir.
Question to
Sorry,
Vikash,
sir?
sir. Question to Vikash. Vikash,
Sir.
you said you will use rituximab. I want to know, now she is an asymptomatic patient. Do you want to use rituxi now?
Sir, this attack, I believe I missed the part. I think this is now just in the subacute phase. No, sir. This is an acute attack.
Completely resolved.
Completely resolved.
Completely resolved with IV methylprednisolone. That was 6 months ago, and she's asymptomatic for 6 months.
Oh, that is, okay. So I missed that part. I thought this is an acute case and patient is still in the first month of the
So
disease.
fertility issue also there.
So if it is 6 months, sir, I would strongly recommend to do a very good quality MRI in this patient, first of all, rather than deciding DMD first. So I will do a double dose contrast, good quality 3 Tesla or a 1.5 Tesla MRI, and then see what is the level of the lesions. If we are thinking of MS, patient may be asymptomatic, but patient may have radiological active lesions. So an asymptomatic
Accepted.
so that in that case, suppose we get a radiological positive lesion in this patient, then the patient qualifies for a DMD, because this will be taken as a, in the newer criteria, this will be taken as a dissemination in time.
Anybody else? I will ask Dr. GA to comment.
I think I agree the last one. It was my daughter. I would not start immediately.
Yes.
I'd like to follow up, do a better scan, and do monitor with the scan. I'm not in favor of the first attack.
Sir, others please mute. Others please mute your mute your audio, please. You are disturbing. Others please mute your audio.
Can you hear me?
Yes,
Yes,
sir.
I can hear you.
Yeah, okay. After all the discussion, first of all, like we do in institute, the diagnosis should have been demyelinating disease. Next discussion was what kind of demyelinating disease. There are two temporal lobe shadows. In MS, where do you get temporal lobe shadows except periventricular? Only in encephalitis. Somebody raised the point. And Bhupati raised the point. Anyway, having gone through all that and the responses, now we are talking of the future. She definitely had OCD. There's no doubt about that one. He's talking about the future. I am not one of those who jumps into preventive. We've done preventive treatment, monthly rituximab and all that, in people who got massive lesions and who recur. Mind you, here the cord was involved. Was she paralyzed?
No, sir.
No. So this is the danger, that if you wait, get a bigger attack, we may recover the lesion, but we may not recover from paraplegia. My decision would be that I will wait and watch. I will we'll follow with MRI, contrast, double contrast, to locate any active lesion. If there is an active lesion, I would treat.
Yes.
Because the life of the person is also important. We all forget, we only worry about the disease. We must worry about the person who has got the disease.
Yes.
She may say, I don't care, I want to get married, I have children. Her choice is very important.
Exactly.
That is what she has expressed, sir.
Sorry?
I think, Saravanan, you'll have to tell them what she has told you.
Sir, was a new MRI done, sir, in this patient? Fresh MRI was done?
So second MRI was done, sir, a month back, so it was normal.
No, have you done a double contrast MRI?
Double contrast MRI was not done, sir.
That is the point. So you need to do a very detailed MRI in this patient. We cannot accept a suboptimal study in this particular case, at least.
We did a 3 Tesla MRI only, sir. It was, there are no.
The other sensitive marker is, if you repeat the CS after 1 month,
Yes.
OCB is still present. That's a sign of activity. Hello?
Yes. Yes. Is everybody commented? Hello, anybody else wants to comment? Hello?
Gone dead.
Sir, your comments, sir. Professor Zahir,
My
sir, your
comment.
comments.
Yeah, I'm going to comment it. So I think this is most likely an MS. Very likely. I can't imagine any one of the other ones, that is the emoji and NMOs, presenting so clearly and disappearing so quickly. I doubt it. Especially when the oligoclonal band are present, as well as other stuff. Oligoclonal bands and monoclonal antibodies are present. Now, I don't think you see both of them with such frequency in the other two entities. Now, as far as treatment goes, I'm one of those who prefers fingolimod. We'll have to wait and see, as Dr. G has said, maybe repeat another scan, better scan, and probably wait, as somebody suggested, if she gets another attack at all. If she doesn't get an attack, we don't do anything. If she gets an attack, maybe start it with prime her with methylprednisolone and then put her on fingolimod. And yeah, Avonex is okay, but I mean, most people get fed up with it because they have to take an injection. As a matter of fact, my experience is a lot of people get fed up with disease-modifying therapy itself because it's expensive and it is an average man cannot tolerate the cost.
So Natarajan,
Yes, sir.
sir, did you come across a complete resolution of lesion after a steroid treatment in MS, sir? Any one case?
A number of cases do respond, sir. I don't think that's
No.
point to stress. It is
Number of
not
cases will respond. Do you get complete resolution of all lesions? That is subcortical, brain sham, and spinal cord lesions?
Sir, in this patient, there were only 2 spinal cord lesions and 2 lesions in the brainstem.
3 lesions. I know 3 lesions.
No, generally, when there are few lesions, yes, sir, they respond. But when there are multiple lesions, you don't get a complete response. And regarding one other point which you raised, is regarding the neurofilament light chain. Neurofilament light chain is not specific for any particular disease.
Yes,
It's not
that
specific.
I can tell you.
It can
That
happen
is
in
not-
several disorders.
Yes, sir. Yes, sir.
Neurofilament
What
light
about
chain
the
is not a
VPs?
diagnostic thing.
Same thing works good for monoclonal antibodies also.
Professor Natarajan, what about the serial VEPs in this patient?
Now you're coming.
Sir, Vikash, you should ask Saravana, not me. I don't know whether
Sorry,
it's
sir.
No.
You're not.
Sir, VEP was done
Natarajan.
once, sir. Once VEP was done and the VEP was normal, sir. Both amplitude and 300 latencies were normal.
When was that, doctor?
What
So
about
there was
300 latencies?
The 300 latencies were normal on both sides, sir. We did on both eyes.
Now
Both were
you
normal.
see, there is
When
one.
was that? Which part of the illness? Whether acutely or follow up or when? Timeline is very important here.
Sir, this was the VEP was done only after giving a IV methylprednisolone, sir.
So that is 6 months back. So we don't know the ocular status right now.
So
That is the
presently we have
point.
not done. VEP was not repeated after that, sir. One plated VEP was normal. Then when we repeated VEP, sir.
VEP and OCT should be done in this patient along with a very good double contrast MRI. That is my
Hello.
dad.
See,
Hello.
you should understand Vikash is very academic and aggressive person. So
Sorry, sir. Sir. The
The
second day I will like to withdraw, sir. Second day I will
Hello.
like to withdraw.
I'm only complimenting you.
Can I make a comment?
Sir.
If you
Sir.
have a ophthalmologist who is assessing the thickness of the retinal layer,
OCD,
just come very
Yes.
recently.
Yes.
OCT.
This is very important.
OCT.
Even if you don't have an optic nerve lesion, and
Exactly,
in patients
sir.
who have and in patients who have multiple sclerosis, ultimately you will see that even without an optic nerve lesion, the retinal layer will start getting thinning.
Wonderful, sir. That is why I was telling about OCT in this patient. We are,
As
as
a
a
matter of
neurologist,
fact,
I feel
excuse
we are
me,
not
one minute.
using that test very frequently.
Because for 1 minute, I can tell you, this particular test will differentiate from emoji, will differentiate it from particularly assessing the thickness of the retinal layer.
Sir, one comment, sir. We have not come to the stage of managing multiple sclerosis based on the report of OCT. Even if the OCT is abnormal down the line, there are no studies saying that when it gets worse or when it gets involved. Sir, somebody, can you mute your audio, please? Senthil, can you mute your audio, please? Senthil, can you mute your audio? Yes, thank you. Sir, we have not, this is to Vikash also. We have not yet reached a stage on deciding on disease modifying therapy or whatever therapy is based on OCT. That is, if you find OCT to worsen over a period of time, are we to intervene and change the dose of the medication which we are giving, or change the drug or start on a new drug, we still do not have evidence on it. If anybody knows that OCT, based on OCT, we have to modify treatment, please let know.
No, I don't think, you
No,
see,
sir.
thinning of the retinal segment, thinning of the retinal, demonstration of the thinning of the retinal segment does not deserve a change in treatment.
Yes.
Yeah,
So the
prognosis.
idea is to get as many ancillary tests possible. That is the idea, sir. But I don't think I agree totally fully with Dr. Vian, sir, that we cannot decide only on OCT. But that will give us a clue. That's what is my point.
For the diagnosis.
Yes, sir. Exactly, sir.
Correct,
For the
correct.
diagnosis.
Accepted, accepted.
Not for the treatment, sir. Not for the treatment, sir.
Not for Natarajan. Hello,
Yes, sir.
Natarajan.
Yes, sir.
Still, even today, besides all the tests, you can do, but so far, the most sensitive has been thinning of the retinal layer, ganglion cell layer.
Yes, sir.
Most sensitive. And you can't detect therapy on it, but that has been the most sensitive one.
Yes, sir.
And
Everybody
this-
agrees on it, sir. I think
No.
nobody disagrees, sir.
No. But if this is present, then other entities don't come under question. It is a mess, that's all.
Sir, almost all the demyelinating will show that, sir.
No, all the demyelinating will not show a decrease in the retinal layer, Natarajan. None at all really, except demyelinating, except multiple sclerosis. Hello?
Yes, sir.
Any other comments? No?
Can move on to the next presenter, sir.
Nimshan, Dr. Radha is there. She hasn't commented. Hello?
Dr. Radha?
Yes, sir, I'm here, sir.
Yes, sir, Radha.
You're the second presenter. I think you should be commenting something on the first case.
Sir, again, I go with Dr. Natarajan, sir. I feel it's a case of MS. Actually, disease-modifying agents I usually reserve for the second episode, sir. I generally don't choose it for the first episode.
Okay.
So we can wait
Good
the nature
enough.
also to answer, sir.
Good enough. That's good. Dr. GA, can we go to the second case now, or would you like some more commentary?
Sir, we
I
just
think we
thank
had
Saravanan
enough.
for the patience, sir. Saravanan for the case.
Thank
sir.
you. Thank you.
Thank you, sir. Thank you, sir.
Arunam, thank you very much for such an interesting case and a discussion following it.
Thank
Dr.
you, sir. Thank
Radha,
you, sir.
now you can start presenting you can show your case now.
Yes.
Sir, Zahir, sir.
Yeah, Choluba.
Good morning, sir.
Morning.
Professor GS, sir.
I'm ready, sir.
Good morning, sir.
Namaskaram, Bhagandaram.
Bounder, sir. Bounder, sir.
Namaskaram, sir.
Bhupati
Thank you,
Bhagunara.
sir. Sapte, sir.
Can I, sir?
Yes,
Yes,
please do.
Radha.
Go ahead.
Yes, sir.
Good morning, Radha.
Morning, sir. Morning, sir.
Good morning, good morning.
Madam, you are on slideshow. You can take off the slideshow.
Yes, sir. Respected professors and all my senior colleagues.
1 minute, Radha, 1 minute.
Yes, sir.
Professor Zahir, sir, can you just
Yes,
introduce
sir.
Radha as an associate?
I have met her now several times, VN,
Yes, sir.
at the Neurotrust meetings.
Yes, sir. So Radha is an associate professor of neurology at Tirunelveli Medical College, and she is going to present her case. Yes, Radha.
Thank you, sir. Thank you for the nice opportunity given to share my cases, sir. And I sincerely thank all my senior colleagues to have an opinion here. The patient is a doctor, sir. He's an ophthalmologist, 57-year-old, who have presented to my OPD with the following complaints. He had an 8-month duration of complaints with slowing of activities. And he was a bit slow in his activities. He used to be very fast in seeing his OP. Now, for the recent time, he is having a bit slowness in doing his activities. And it's also actually noticed by his wife, who is also a doctor. And he also has disturbances of gait. He has a tendency to fall at times while walking, and the tendency to fall backward is predominantly more when compared to that of other things, and he had never history of fall is there. So he has a tendency to fall backward, and he has a profound disturbance of gait also, which is noticed again by him and also by his wife and also by his colleagues, who also noticed him to have an episodic, confused and agitated behavior. He usually not used to be like that in his workplace. For the recent past, he used to be a bit more confused in his work, in his procedures also. And other persons working with him also has noticed some confusions in him. And agitated behavior, particularly his wife has noticed both in the daytime and also during the night times. And he also had complex visual hallucinations, which he often described to his wife, particularly again more during night and also during the daytime. And sometimes he is also able to describe the complex visual hallucinations at times, not always, sir. This was the history with which we came to his, he came to my OPD. So his past history is not that significant, apart from that he is a diabetic for 10 years duration with a moderate glycemic control. And the patient was hypertensive for past 7 years, and he is on treatment and is on regular follow-up also. And he is a chronic smoker, and occasionally he takes alcohol. On clinical examination, and I found him to be more talkative. Usually before I met him, he was not that talkative, sir. But while sitting in my OPD, he was actually continuously talking. Previously, I have not seen him like that, actually. And he was also noticed to have a bradykinesia of his motor movements. So he was a bit slow in moving and bit slow in handling the objects and other things. On examination, he had a mild restriction of a vertical gaze. His horizontal gaze was normal, and circuits were a bit slow. And he has a tendency to fall backwards on getting up. And patient was found to have an increased axial tone, particularly in the neck. And he had a gait impairment, as previously described. It was a combination of slowing of activities and it was a short, not as just as short shuffling stuff, steps like. The gait was abnormal and it was slow, and on propulsion and retropulsion he had an abnormality, and on examination his ankle jerk was absent. I have just given only the positive findings, sir. So this was the MRI brain scan done. Sir, I'm not able to produce the image here as his wife has misplaced all the images, but I will give all the reports, sir. And I will also give an image which I retrieved from the server, sir. So as this, you can see that the MRI brain showed a diffuse cerebral and cerebellar atrophy with a ventricular dilatation, and no other findings were seen. And MRI cervical spine showed a spondylitic changes, and nothing else was visible, sir. So I stop here for a moment, sir, for the others to comment on it, and then I'll proceed, sir.
What about cognition?
Sir, cognition, he was good enough, sir. Apart from confusion, he used to routinely attend to his hospital chores also, sir. Cognition was not that much of a difference, sir. And memory is also pretty intact, and sometimes he gets confused.
No sleep disturbances?
Yes, sir. Actually, sleep disturbances was there, as I mentioned. He used to get confusions during his sleep, and also sometimes he has a complex visual hallucinations also, sir. And the restless leg movement and periodic leg movements of sleep was not noticed, actually.
No sleep apnea?
Sir, I'll give you in the back, sir.
Can I go, sir?
Yeah.
Straight away, this looks like one of those Parkinsonism, not Parkinson's, Parkinsonism disorder. And amongst those Parkinsonism disorders, I would probably put Lewy body disease as the first possibility. Reason being that there is significant complex visual hallucinations and confusion and agitation. The rest of it, of course, is common to any of those Parkinsonism disorders. But because of this features of complex visual hallucination, agitation, and confusion occurring quite early in the disease process, I would probably think, at least theoretically, of a Lewy body disease. Of course, if Radha is going to show other disorders, particularly if she's going to show sleep disorders, sleep disturbances, and since the only disturbing factor is for a Lewy body disease is just of 8 months duration, and he is 57 years old. This 8 months is more in keeping with rather a chronic process, I would think of a subacute process. And any subacute neurological deficits, particularly if it is subcortical, that is the cognition being spared, we would have to think of autoimmune disorders. And in that context, with hallucinations, agitations, confusion, and if there is a sleep disturbance, I would consider an IGLON5 first. So my take would be a Lewy body disease, but the chronicity is not there. And if there are sleep disturbances, which is a major clue, then I would think of IGLON5 antibody disorder.
Sir, can I just discuss at this point if there is time? Just a
Please,
comment.
welcome.
Please do.
So, sir, very, very good case, at least at the whatever Dr. Radha has presented. So basically, we have two domains here involved. One is the visual hallucinations and complex hallucinations, which is favoring a frontal kind of a DLB variant or a Lewy body variant. But at the same moment, within 8 months period, we have a significant vertical gaze impairment and falls, which Dr. Radha mentioned. So how do we amalgamate these two things together? If I like to see this together, I would like to consider a very early frontal variant of PSP. Now, that is also atypical. So if you see Kailash Bhatia's group, there was a paper which was produced, and very excellent paper, atypical Parkinsonism. So because it is a short history, I would really like to investigate in detail for a secondary causes. So what are the secondary causes I can think in this patient, which can present as a frontal PSP, but as a secondary cause, like a atypical presentation of a frontal PSP. Number one, calcium levels and parathyroid levels. Number two, since he's a smoker, I would like to rule out any paraneoplastic syndrome, whether there is a lung carcinoma in this patient or something else which is presenting like this. Number three, the other genetic variants which presents like dynactin or peri disease or even MAPT, progranulin mutations, those atypical variants of this frontal PSP will be considered if, as Professor Natarajan rightly put it, or even IGLON5, if there are other things like sleep disturbances or much more ocular findings and other things, as Dr. Radha is going to show us in the future slides.
Sir, one more addition. Dr. Radha mentioned that the ankle jerks were absent. Of course, he is a diabetic, so
yes,
that is always there. But,
yes, sir.
But since it's mentioned, I would like to know about the B12 also, because several times we've been fooled. Many of these disorders, particularly subacute in onset, have been due to B12 deficiency.
Yes,
so I would include that also in my differential diagnosis. Probably IGLON5, diffuse Lewy body disease, and B12 deficiency. These would be my differential diagnosis at this stage.
So for me, it is frontal PSP, secondary causes like parathyroid, calcium, or a lung cancer. And third will be the other genetic variants, and including that. B12 presenting as complex visual hallucinations, I am not very sure, sir.
Hello.
Somebody
else wants to comment? Hello. Hello.
Proceed, sir.
Can you hear me?
Yes, sir.
Yeah.
Okay. I think in any clinical condition, like Radha went through, you are given a case, you're given a pattern, and based on that pattern, just on delusion, hallucinations, Natarajan came up with a beautiful diagnosis, pattern diagnosis. See, all of us don't go through all the diagnoses. You have a provisional diagnosis. Then, as the second speaker said, you find out it's primary or secondary. If it is a short duration, nowadays the modern thing is autoimmune disorder. And we are finding some cases which have autoimmune positivity. Whether they get treatable or not is a different question. So I think this is how we should discuss the case. The very fact that how many cases that you see in a year have got visual hallucination and organic brain syndrome. There are very few. That's why it's very interesting. A person who is able to tell you about visual hallucination. So I congratulate Natarajan making a clinical pattern diagnosis, like doing DMD, weakness, proximal muscles, time lag, etc., gives you a pattern diagnosis. So I agree that I would start as Lewy body disease, and then I don't know how long was the duration. I would
8 months.
pitch in for all the tests. As far as B12 is concerned, B12 that I have seen, I call it occult B12. You see a clinical picture and then you think of B12. There are many other conditions that fit. B12 is so simple to measure. I don't think we know all about B12, but memory problems come quite early in B12 deficiency. So I think, yes, as a teacher, as a clinician, that I will make a pattern diagnosis, and then this will, I call it PD plus syndrome. Then go for looking for the causes.
Any
Yes. Hello.
GI symptoms were there, Dr. Radha, like celiac-like symptoms, because posterior cortex epilepsies can present with visual cortex, visual hallucinations, and some Parkinsonian kind of overlap there.
No GI symptoms as such, sir. Can I proceed?
I just want to comment. I mean, I agree that the first thing would be Parkinsonian syndrome, whatever you want to call it, Lewy body disease. The other possibility, because of restriction of vertical gaze, which is what she's pointing out prominently, I hope we are not missing a PSP. That is, we are not missing a PSP.
So a typical Lewy body within 8 months with vertical gaze and falls is very unlikely.
It does not come.
Very unlikely.
Does not come. Rare.
Very, very rare, sir.
Yeah. Particularly with restriction of vertical gaze.
Exactly, sir. So that's why a frontal PSP I was favoring more as far as the syndromic diagnosis is concerned.
See, in a atypical Parkinsonian syndromes, PSP becomes one entity. So that's why I think PSP, I would like to consider PSP as a very serious entity.
So, sorry, Vikash.
Go ahead.
I agree.
Sir, 1 minute, sir. Vikash, I missed your comment. What did you say is very, very rare?
Sir, within 8 months in a typical Lewy body PDD-like syndrome, sir, it is very unlikely to have an up-gaze restriction with falls. So that is
not
one
just
point.
up-gaze restriction, Vikas. I'm
So
talking
vertical
about
gaze
vertical gaze restriction in an
Yes, sir.
average Parkinson's. When you see, as the age advances, you will have an up-gaze restriction to some extent.
Yes,
But
sir.
both vertical gaze palsy in a PSP at 8 months is, uncommon, very uncommon.
So that is what
Yes.
Dr. Radha, can you
was
clarify
my
what
point, sir.
exactly is the
Axial
vertical
rigidity,
gaze?
vertical gaze disturbance, and falls.
It is an upward
She
gaze
also mentioned about
restriction.
axial rigidity and falls.
We'll go with the
Yes,
findings.
sir. And axial rigidity and falls.
Sir, Karthik here, sir.
Radhika, was the doll
Karthik.
child normal?
Oh, sorry.
Dolce was normal, sir. It was maneuverable only.
Sir, Karthik here, sir.
Karthik
Just a
is on the
comment,
line,
sir.
sir. Yes, Karthik. Karthik, you wanted to
Hello.
ask something? SNK?
Yes, sir. I'm happy to listen to all the experts, sir. Nice discussion. Sir, as everyone's talked about autoimmune, I think specifically we need to look at Hashimoto's in this patient. That would be one differential which I would like to rule out.
Why suddenly?
Because of the hallucinations and presence of cognitive changes. Cognitive changes are not there, but I think the presentation in this age group, we need to rule out Hashimoto. Without the MRI, I would have thought of subdural hemorrhage, chronic. With the imaging, I would try to rule out Hashimoto.
Why Hashimoto specifically? What makes
Because
you think
that
of
is not
Hashimoto?
thought of.
No. Thought of it. Any particular clinical history makes you think that this is a Hashimoto's.
Karthik, how many Hashimoto's you have seen with falls, gaze restriction, and complex visual hallucination? Is it very common? Is it very common? I mean, it can be Hashimoto's, but this, if we discuss, I mean, I would like to discuss this in the form of taking all the hard signs into consideration.
So what autoimmune are you thinking of?
Karthik? I just discussed all those points actually.
Dr. Radha,
Anybody else? Bhupati.
can you just elaborate on this ocular findings and how often does he fall?
Sir, there is no history of fall. There is
Very
a
good.
tendency to
Yeah,
fall,
that is
sir.
important because
Nalla
Vikas keeps on saying false, false. I thought I heard you saying no false.
No, sir, there was a tendency to fall, but he has
That's
never.
all.
Sir,
Vikas,
that-
there is no fall, Vikas.
But
Right.
the gait is not normal, no.
No, that is different. No, you are harping on false.
Sir, the
See,
balance is not
several of-
normal, sir. That
several
also
of these
favors a UPDRS score, so false.
Several of these Parkinsonism
Sure.
patients have a tendency to fall, and particularly as she mentioned, they always tend to go backwards. And that is why they have this postural instability. When you pull them backwards, invariably they show that.
Yes,
But
and she
that is
mentioned
that is not equivalent of a false when we discuss about false being a clinical feature.
the
that is
axial
one.
rigidity was very significant. That's what she mentioned.
That's fine. That's
So
fine.
that
Radha,
also will.
what about ocular movements? Can you just describe once
Sir,
more?
there was a vertical gaze restriction, sir, down more than up. And Sackett's horizontal was slow, but it was full, sir, actually. Movements were full and DEM is normal. It was maneuverable, sir.
Can I ask a specific question?
Yes, sir.
Now you have seen Parkinsonic patients.
Yes, sir.
Now this vertical gaze which you are describing, does it go with just Parkinson's or does it make you think of a separate disorder wherein this is involved? I'm asking you a specific question.
Sir, I thought of Parkinsonism only, sir. I didn't think of Parkinson's like in the first visit. Since it was vertical gaze restriction and axial rigidity was more, clinical diagnosis naturally will be an PSP, sir. But there were certain points against that also with the presence of complex visual hallucinations, and the duration is very, very short, 8 months duration. I specifically asked them again and again. They said it's only 8 months.
And both are doctors?
Yes, sir. Both of them are doctors, so we have to believe them, sir.
That is why the frontal variant, Dr. Radha, of PSP.
Fine, sir.
Yeah, that is one of the differential diagnoses, Vikas. Yes.
Yes, sir.
Madam, is he an alcoholic?
Yes, sir. He is an alcoholic, but it's a party drinker, sir. He never takes alcohol on a regular basis.
Liver function tests were normal, sir.
Sir, he has hepatitis. I will tell you, sir, actually.
Thank you.
Vikas, one more point. Even for a frontal variant, 8-month duration, so much of subcortical without much of frontal lobe features.
Exactly.
You'll have to
That's why
consider that.
atypical, sir.
Yeah, okay. Okay. You are
Just
a
1
movement
minute.
disorder
I
man.
think she has given
I
the
know
clue
you are
already.
I know you are a movement disorder man.
I think she has given the clue already. Rare
No, sir.
presentation of common disease.
Yeah, exactly. Exactly, Vijayan. So what do you think?
I don't know. I would want to look into the liver function test also.
No,
Does he have a chronic liver disease?
That more sounds like B12.
Fine, fine. I
goes
agree with
more
you,
into
sir.
our
Hashimoto, B12, other autoimmune encephalititis, paraneoplastic syndromes. Of course,
They're not,
everything would come into play, and including chronic liver disease. Thank you.
Hello? Yes, somebody else. Bhupati, are you going to comment? Hello,
Bhupati
Bhupati.
has disappeared.
Bhupati
Bhupati
sir,
has disappeared.
unmute sir, you are muted sir. Bhupati sir, please unmute.
Bhupati is gone home.
Saravanan, you want to comment?
Saravanan?
He's
Saravanan
also
is
gone home.
Gone home.
Sir, no, sir, I am here, sir.
Ah, did you want to
I
comment?
consider diffuse Lewy body disease as the first diagnosis, sir.
What is your disease?
Diffuse Lewy body
Diffuse
disease.
Lewy body disease.
Oh,
Yes,
Lewy
sir.
body disease.
Yes, sir.
Okay,
Because
anybody
of the
else?
presence of complex visual hallucinations, sir.
Anybody else?
Dr. Zahir Biswakumar, I would go with you
Sir, Biswakumar,
on
please
that
comment.
PSP, on that PSP and a Lewy body disease. I would like to know if somebody has given him a Syndopa or any other drug which produced the hallucinations.
He was not on Syndopa previously, sir. I only started him on Syndopa. I'll tell you, sir, what happened after that.
Radha, I believe
Yes, sir.
there are some questions in the chat box. Parni has posted or somebody has posted. Can you just see? There are some chat box, there are some view comments or questions. I
I'm
don't
not
know.
able to visualize chat box from here, sir. Can I answer
Okay.
at the end, sir?
Ibrahim,
sir.
sir, how do you get to the chat box?
Sir, the corner we have a chat box icon, sir. From that,
Does the speaker get to it? Does the speaker have it?
speaker can't open, sir. Individuals can open.
Okay,
Ma'am,
so
ma'am, you can.
Sir,
please,
sir, anybody can access the chat box, sir. Parni here.
Not able to buy any.
ma'am, please open in a more option, ma'am. Please click on more option, ma'am.
More option, madam.
Fine. Okay.
In that, you
Yeah.
can see the chat, ma'am. From that, you can open.
okay, I'll read it out for you. Looks like DLBD, sir. That is Nikhil. Renuka Devi thyroid profile.
Yes, sir.
And then Nikhil anti-thyroid antibody profile.
Yes, sir.
Parni audio is not clear. So these are the comments there.
Yes, sir.
Natarajan,
Yes, sir.
what is DIBD?
DLBD.
Sir, DLBD is diffuse Lewy body disease, sir.
Oh, okay, thank you. All right, any other commentary? Or shall we ask? I'll comment what I would think. I think this is a problem, I mean, variant of a Lewy body disease, but much more a patient with PSP. Now, much more as a patient with probably a PSP, particularly with vertical restriction of gaze and in such a short period of time. Now, can a PSP picture be produced by some other factors? Yeah, it can be. For instance, lithium intoxication produces PSP. And sometimes even these paraneoplastic borders can produce PSP. So let's wait for Radha to say what she has.
Yes, sir. I'll proceed, sir.
No psychiatric history, no psychiatric drug history or
No, sir. No history. He was obviously not. I only started him actually on and.
Okay.
1 minute, Radha.
Yes, sir.
Native medicine.
No, Ramasubramaniam, sir, are you there? Professor Ramasubramaniam? DRS, sir?
They're gone for lunch.
No, I saw Ramasubramaniam's name flashing up. That's why I asked him, sir. Okay. Rather, you proceed now.
Yes, sir. Thank you, sir. Exactly like what we discussed, sir. I thought of the two possibilities. One, it could be atypical Parkinsonism due to some other cause, or it should be a Parkinson plus. So in Parkinson plus, there are 4 points to something and some points which are against actually. For 4 points for supranuclear palsy there was a bradykinesia, tendency to fall, especially backward, axial rigidity, gait disturbance and vertical gaze restriction. And for Lewy body disease, he has a behavioral disturbance, complex visual hallucinations. In addition, also he has some extrapyramidal symptoms. So I started him on a mild dose of Syndopa, sir, and also I started him on a mild dose of QTFL. Actually, neuroleptics has worsened this disease and complex hallucinations has become more when I started him on QTFL. And with Syndopa, the bradykinesia definitely improved for a while. And since both of them are doctors, I want to get a reference from higher centers also, sir. So I referred them, I suggested them to take a PET scan because to some extent we can differentiate between Parkinsonism plus disorders from PET scan. And for further evaluation and for expert opinion, and the referral center where they went was CMC Vellore, sir. So the lab investigations that were taken at CMC Vellore was serum ammonia was 7.1, which was within normal limits. I am presenting only the vital parameters, sir. So the routine parameters I have not included. For Vikas, serum calcium was normal. Parathormone we didn't do, sir. And for Vijayan sir, his SBS AG was positive and he has a low viral load. Apart from that, his liver function test was also normal. Vitamin B12 and folic acid were normal. Serum electrophoresis done, it shows a normal pattern. Thyroid profile was within normal limits, and anti-thyroid antibodies, thyroglobulin and thyroid peroxidase, both were negative. They have done an ANA, SSA, SSD and entire ENA profile that was again negative. They have done an anti-GAD antibody, which is negative again, anti-neuronal and onconeuronal antibody profile. Since he's a smoker, they also thought of the other things and it was also negative. Anti-PR3 and anti-NPO for vasculitis again was also negative. So they've done a CSF study. So protein was 68 and they attribute it to high blood sugars according to them. And it was a acellular, and viral panel done was negative. Mycobacterial culture was negative. Fungal culture was negative. And the entire autoimmune panel, which is generally done, is negative. This is the MRI where they repeated again in CMC Vellore, which again showed an cerebral and cerebellar volume loss with ventriculosulcal disproportion, and there is dilatation of the ventricles. They also thought of the possibility of NPH. They also did a CSF flow study, which again turned to be a normal, sir. And whole body PET was done in this patient. It showed a global hypermetabolism, hypometabolism rather, with diffuse cerebral and cerebellar atrophy with mild hydrocephalus, and basal ganglia showed a mild hypometabolism, and entire body PET was normal.
Where do you stand?
Dr. Radha,
Yes, sir.
you said you will tell us something about the sleep.
Yes, sir. It will come in the next clinical episode, sir. It will come in the next clinical episode, the first clinical episode, sir.
Oh, okay.
Fine, sir. EEG done during the time of first evaluation was normal, and nerve conduction study show an polyneuropathy with a bilateral S1 radiculopathy. Again, they attribute it to diabetes. VEP studies done showed a bilateral anterior optic pathway dysfunction. And again, in December, sir, you want to comment at the end of all this investigation, sir? Can I stop there for a while?
Yeah. What do you want?
Sir,
Comments.
Oh, comments. Well, I mean, you see, Natarajan, interestingly enough, none of the investigations have showed up any abnormality.
Sir, as you are very fond of, the
Pardon
VEP
me?
is prolonged. How do you interpret it, sir?
VEP is prolonged is okay. That will be that will only tell you that it is a disorder of the dopamine carrying systems. That's about all. That will probably favor Parkinson's.
Sir, VEP, sir? Yeah,
VEP,
okay.
yes.
Okay.
That is favor Parkinson's.
Okay.
Now, what I was going to ask is why not get a DOPA scan done and see how FDoxyglucose or the DOPA goes into the substantia nigra cardiac GP.
Sir, FDG PET was done, sir. It doesn't show any abnormalities. There was a global hypometabolism of basal ganglia alone. Yes, sir.
No, but
nothing specific came out of it. They were not able to conclude at the end of FDG
Dr.
PET
Radha,
also.
sir is asking about DOPA PET.
Radha, what about
DOPA PET.
PRODAC?
No, sir. DOPA PET was not done, sir. Only FDG PET was done.
I think that
question is,
I only said,
to ask you,
hello.
why would you go for a PET scan? PET scan is seldom
I don't think a
helpful.
PET scan is necessary here at all.
It's become a fashion to do PET scan.
Yeah.
You can't get a concrete diagnosis from a PET scan.
Nobody, you can't.
Invariably, it's a muddle. It's a confusion. So far, I have not asked for it, but I've seen several PET scans being asked for dementia. And I've never ever had a conclusive report out of those PET scans. The question now Professor Zahir is asking is a PRODAC. If you want to differentiate
Is that
a
what you call a DOPA scan?
Yes, sir.
No, sir. TRODAT is different from a typical DOPA scan, sir.
I am asking for a DOPA scan.
Yeah,
To see the transfer of DOPA carrier into the...
DOPA PET is different from TRODAT, sir.
I don't know about this product, but I want a DOPA scan to see the functioning of the substantia nigra, GP, subthalamic nucleus, and the others. Come on.
Madam, Radha, madam.
Sir, here we did PET because he was a smoker, sir. We also want to rule out other autoimmune, other paraneoplastic manifestations also, sir. In that, the brain was also included, actually.
Madam, Radha, madam.
Yes, sir.
Okay. No, you did a PET to find out brain lesions or you for...
No, sir, we included both, sir, actually, both. We also want to rule out paraneoplastic because he was a chronic smoker.
Madam, Radha, madam.
Yes, sir. Yes, sir.
Madam, whether the patient has got an obstructive sleep apnea?
Sir, I'll come to that, sir.
Because long-standing obstructive sleep apnea can present with cerebellar sign, Parkinson's sign.
Visual hallucinations and other things also, sir.
Excuse me, I'll put it the other way around. I mean, dopamine system involvement will produce sleep apnea.
Yes, sir. Yes, sir.
You understand? It's the other way around. I mean, sleep apnea does not produce this. Unless it is an obstructive sleep apnea, then it's a different piece of cake.
Obstructive sleep apnea. Yes, sir.
This is not obstructive sleep apnea. Hello.
Some history has been hidden so far, sir.
No, sir, I have not hidden anything. It's coming in the second event, sir, actually.
Okay, okay.
Fine, sir. Again, they went to CMC Vellore. They came back without a diagnosis, and the patient was still continued on DOPA. We stopped neuroleptics. They had melatonin for sleep disorder. So, patient continued to work actually. So, again, patient one
Can we
day
have a
while he was
little
sitting,
silence?
patient was brought to casualty one day while was working in a OP in an unconscious state, sir. Actually, madam said that he was found unconscious at home. They don't know much about the history. So on about inquiry about seizures, trauma, drug intake, fever, nothing came positive. On examination, the patient was unconscious. His pupil was equal reacting to light. EOM was full. There was no focal neurological deficit and no neck stiffness also. And while on investigation, he found to have a diabetic ketoacidosis with UTI. And all the routine investigations, including sodium, ammonia, LFT, everything done at that time again was normal, sir. I was not able to explain the encephalopathy at all. So immediate imaging was done actually. I retrieved it from the server, sir, actually. These are all the CT pictures of the patient, which again show ventricular dilatation, particularly of the temporal horns, and there were mild atrophy of the temporal lobes also. And cerebellar cuts also showed a mild atrophy, sir. And this is the MRI picture of the patient, which again showed a ventriculosulcal disproportion, and ventricles are a bit dilated out of proportion for his age, sir. So we admitted the patient in ICU and was started on anti-edema measures, anticonvulsants, antibiotics, and supportive management. During night, we found to have a loud snoring, sir. So he had features of sleep apnea, and my anesthetist started him on CPAP actually, and the patient recovered consciousness on day 3. After CPAP, his sleep disturbance completely reduced, and his confusional states also improved, and patient also showed a regression of complex visual hallucinations, sir. So with the add-on history, again, the patient was referred to CMC Vellore for review. So obviously, as my professor Dr. Natarajan sir was asking, and Justin sir was asking, and Professor Zahir sir was also asking, there was a history of obstructive sleep apnea, which is detected later.
Why anti-edema measures?
Sir, we don't know, sir. It was an encephalopathy. I don't know what it is, sir. So immediately I started him on anti-edema measures for day 1.
Hello, Dr. Radha.
Yes, sir.
I want to hear from you. Why does this patient have sleep apnea?
Sir, it was found to be an obstructive sleep apnea with sleep study, sir.
When you mean obstructive sleep apnea, he is not obese. Has he got tonsillar enlargement?
Not so, sir. He is not lean also, but he is not definitely obese, sir.
Has he got tonsillar enlargement?
No, sir. No,
He's got adenoid involvement.
No,
So why do you say it is and without it, and not being a fat patient, obese patient, why does he get sleep apnea? He gets sleep apnea, yes, but you can't call it an obstructive sleep apnea.
Yes, sir.
Was there a stridor in the night? Stridor?
But you can't call it an obstructive sleep apnea. Now, you want to call it a central sleep apnea? Yes, fine. That's perfectly all right. But an obstructive sleep apnea without adenoid involvement, without a tonsillar enlargement, without obesity is somewhat restrictive, no?
Dr. Radha?
Yes, sir.
Did the autoimmune panel, which was done for the first time at CMC, did it include IGLON 5?
Sir, I'll come to that, sir. You're already on to the diagnosis, sir.
I told you in the second, that was my second diagnosis.
Yes, sir, it is actually on. I'll come, sir. The next slide is that actually. So again, IGLON 5 was included, both in serum and CSF sample was done after the presence of obstructive sleep apnea and recurrent confusions and complex hallucinations with atypical Parkinsonism-like presentation. IGLON 5 was positive, sir.
What was positive?
IGLON 5, sir. It's an autoimmune antibody, sir.
Yeah.
So this was the final diagnosis, sir. Honestly speaking, I have not heard of IGLON 5 previously, sir.
Yeah, still we do not know whether it's an autoimmune disorder or a degenerative disease.
Yes, sir. I'll come in the discussion also regarding that, sir.
Yeah.
The patient was started on immunoglobulin and patient had a very good clinical response, both in motor and also in his confused behavior, and he retrieved back to work, sir. Now he is on monthly rituximab as per the CMC advice, and patient is also on a dose of melatonin.
Iglon antibody.
And also CPAP, sir. He is regularly on CPAP. Even now after immunotherapy, he wants to have that CPAP, sir.
Symptomatic.
Madam, ABG was done at any point, madam?
Sir?
ABG.
ABG, when he was in ICU, we did, sir. There was a mild carbon dioxide retention was there, sir, but it was not hypoxia like. It was a mild carbon dioxide retention was there, and he improved very well with CPAP, so that they thought they'll continue CPAP even at home.
Thank you, madam. Thank you.
It is more like a central hypoventilation rather than an
Yeah,
obstructive
that's right.
sleep apnea.
It's a
Iglon
simple
5 has more of central hypoventilation
Yeah.
rather than
Because
a-
of the presence of associated Parkinsonism also, we can put it like that.
exactly. But
no,
PSP
let
like
me-
presentation of Iglon 5 is
Excuse me.
a
Hello?
bit uncommon. So I think it's a very good case in that term.
Radha,
Yes, sir.
The CSF, did it include an OCB?
No, sir, they didn't include oligoclonal bands, sir.
Okay, thank you.
Sir, can I on to the literature, sir, or it will take time?
No,
You
you have
don't have
time. You
another
have
case,
another
then
about,
fine.
you have
Fine,
another
sir.
about 90, no?
Iglon 5 is a bit controversial disease, sir.
Yeah.
Nobody knows whether it's a degenerative disease or autoimmune disease. If it is a degenerative disease, it is associated with secondary inflammation against Iglon 5. If it is going to be an autoimmune disease, then it is going to be associated with neurodegeneration later because of the accumulation of tau. Iglon 5 is a neuronal cell adhesion protein of unknown function, and postmortem finding in these patients show it is a novel neuronal tauopathy predominantly involving the hypothalamus and tegmentum of brainstem. That explains his sleep disorder and also his falls and vertical gaze restriction early in the course of the disease, sir. So these are all the varieties by which an Iglon 5 can present. Predominantly sleep disorders, sir. That's the clue in these patients. Sleep disorders with parasomnia and sleep breathing difficulty. Patient can have bulbar symptoms also, dysphagia, laryngeal stridor, and acute respiratory insufficiency. And PSP-like presentations also they have reported with Iglon 5. And especially a point to add about PSP is that the CSF Iglon 5 can be negative. For PSP patients alone like presentation, they can have serum Iglon 5 positive. This patient also had a serum Iglon 5 presentation, sir. And they can have a cognitive decline if it learned later in the course of the disease. If it is not found out early, they can go in for a cognitive decline. There are presentations like chorea, neuropsychiatric disorders, dysautonomia, and hyperexcitability can also be there. If there is an hyperexcitability, it will confuse us with Hashimoto's encephalopathy also, sir. It can take a similar pattern and short duration of disease. So this is the MRI findings in Iglon 5 antibody disease. In 46% of the patients, it can be normal, sir. And in abnormality, it can show a brainstem atrophy, it can show a bilateral hippocampal atrophy, cerebellar atrophy. Sometimes it can be hypothalamic hyperintensities. There can be enhancement of meninges also. There can be brainstem hyperintensity or thalamic hyperintensities, which because the collection of case itself is very low, sir. Only 22 cases they have reviewed from the literature. So up to that, they have given the numbers, sir, actually. This is from 57 patients, and what I reviewed is a study from Spain, sir. It included only 22 patients for the clinical pictures, and PET also can be done. It is normal in 50% of the patients, sir. And if it is abnormal, it can show an striatal and brainstem hypermetabolism can be there, and hypermetabolism also in the basal ganglia and sometimes in cerebellum, and also in the cortices like left frontal, temporal, cardiac nucleus, and putamen. So we cannot conclude anything from PET as said. So treatment, usually what will be done is PAT, CSF and serum samples has to be done for Iglon 5. Iglon 5 is not done in India. I think they are done, being done with a collaboration in Oxford University where it is done. And it is taking 25,000 actually to complete the investigation. And Iglon 5 is both of IgG4 and IgG1 subtype. IgG4 is seen in 80 to 90% when compared to that of IgG1. And these patients has got an HLA festivity also, 36 times more prevalent. Both for HLA-DR-B1 and few patients also has HLA-DQ-B1 festivity is there. And treatment is with immunotherapy. What mentioned in literature is corticosteroids and immunoglobulin. But what CMC people following, they are also giving rituximab, sir, as our SAR is receiving actually, our ophthalmologist is receiving, sir. Thank you, sir.
Hello.
Yes,
Dr.
sir.
Radha.
Yes, sir.
Eglon 5, just to add for information, there is
Yes,
a
sir.
company called as Zenix under Dr. Sudhiran's lab,
Yes, sir.
and they are doing Eglon 5 in India, collecting samples anywhere in the India.
Okay,
So
sir,
I have
nice.
received a mail yesterday also, 28th June, from somebody called as Rohit Verma, who is heading in collaboration with Dr. Sudhiran from, I think, Cochin.
Oh, nice, sir. Nice to hear that, actually. I'll get the reference number from you, sir.
Yes, sir. Yes, ma'am. Please. Thank you. Very nice case, actually. The sleep finding is the characteristic.
Yes,
That
sir.
is the point. But it was not there in the initial presentation. That is.
Initially, it was more of parasomnia like, sir. But I think we have to go into the detailed history, sir.
Yeah, it was like a hallucinations which was
Yes, sir.
possible.
Hello. I think you should, I mean,
Very good. Thank
no, excuse me. I think this is a case you should write up first.
Yes, sir.
Yeah.
Second, this is not an obstructive apnea. This is a central apnea
Yes, sir.
because of the hypothalamic and the thalamic lesions. And third, Eglon, what is the expansion for Eglon? Immunoglobulin. Hello, everybody is talking about Eglon. Dr. GA, you know what Eglon is?
No, I don't know.
I don't know. What is Eglon? What is the expansion for Eglon? Natarajan?
Sir, I don't, it's immunoglobulin LON5. That's all I know.
That's only that I knew. I thought it was something more than that. So that's just fine. No, it's a very good, patient. I think it teaches us to keep in mind that I mean, you know, immunoreactive disorders may be more common than what we think. And maybe ask for the profile for the immunoglobulins to see how well we can do it.
It's
Anybody
very
else want to-
important. It becomes treatable.
Yeah, it becomes treatable, that's right. Anybody else? Comment? Lakshmi? Lakshmi Narayan, I can see you. Hello?
Where are you, Lakshmi?
Lakshmi, where are
Can't
you?
see you. Are you with the cap or without the cap?
Lakshmi Narayan, how are you doing? Well, he doesn't seem to respond.
He's gone for lunch.
Oh, sir, he's there. He has to unmute, sir.
Gone for Sapad.
Lakshmi,
Yeah,
unmute your phone.
Yeah, I've unmuted.
That's good. Now we can hear you.
Yeah, correct.
There you are.
Do you have
Where
an
is your
opinion?
Excellent case presented by Dr. Radha.
Yeah, very good case.
Very good case.
Makes you think a little bit.
Yeah.
Should be
Especially
written
when
up.
your patient presents to you with central apnea, central sleep apnea.
Sir, she has one more case to present. Do we have the time, sir?
You have? No, you don't have. You have 13 minutes left. If you want to do that, a very short presentation.
Yes, sir. I'll do it, sir. Yes, sir. Can I complete it, sir? I'll finish it in a short while, sir. I'll run through.
Yes, please. That's good.
Yes, sir. This is a pediatric cases, sir. It's a group of cases, actually. Patient is a 12-year-old male, actually, who presented with right upper limb and face focal clonic movements with secondary generalizations in his 10 years of age. Previously diagnosed to have a benign Rolandic epilepsy, and the patient was started on carbamazepine and clonazepam. He was doing well, sir. For the past next 1 year, he was not having much of an episode, sir. But since last 6 months, he started having multiple episodes of drop attacks, atonic seizures, which lasted for very few seconds, 1 to 2 seconds, rather 2 to 3 seconds, more than 50 per day. He also had episodes of truncal swaying like walking, which was noticed by the patient attender. And this was not associated with loss of consciousness. And also he gets up immediately. And there was no history of febrile seizures. Patient was born out of non-consanguineous parentage. His developmental history, birth history was normal. Family history was not significant. His language and mentation was also normal. And his school performance just before 6 months, because of the COVID, they are not able to assess much about the school performance also now, sir. And mother finds he is concentrating less on school studies now. He's a poor patient, sir, also not online. But so it's very difficult to comment on mentation here, sir. General
You have an
examination.
EEG. Radha, you have an EEG for me to see.
Yes, sir, it's there, sir. So school performance was normal till the exacerbation of the episode. After that, because of COVID, schools are closed. He is not attending school also. And general examination, he has multiple scars over the face, sir, due to recurrent falls. On systemic examination, we found to him have a mild ataxia on walking also, sir. These were his videos, sir, actually. So this is the first video, which shows the head drops, sir, actually.
Subacute sclerosing panencephalitis.
I thought so.
As for
Sir,
only serious EEGs.
Sir, focal seizures, sir, not myoclonus, sir, focal seizures.
This fall, we have seen all of that. The way he goes down on his trunk, subacute sclerosing panencephalitis. Prove me wrong. Radha, please go ahead.
Sir, this is the drop attack while walking, sir. There's no myoclonic jerk, sir. It's more of a negative myoclonus like with the fall.
No. Negative myoclon.
Okay, you have very little time left. Radha, please go ahead.
MRI brain epilepsy protocol done was normal. This was the EEG, sir.
Can we have another part of it?
Yes, sir, I'm presenting, sir.
No periodic complexes.
No, sir, no periodic complexes. It was more of a frontocentral temporal epilepsy type, BRE-like type.
More on the left side, no? Radha,
More on the left side, asymmetrical, sir. More on the left side than on the right. And it was
This is bilateral. I think this is the fact that it is showing up more on one side is just an artifact.
Sir, clinically right fatiobrachial, and it shows more on the left side, sir.
Yeah, that's it.
Sir, this complex has occurred continuously throughout the EEG, sir. And increased during sleep, sir. I was not able to run the EEG here, sir. So this is a case 2, sir. I'll put all the cases and then I'll come for discussion, sir. Here is a 3-year-old male child. Again presented with the similar features of head drops more than 20 days for 2 seconds each. No other type of seizure was seen in this patient apart from the head drop. His gait was normal. Mother is noticing aggressive behavior, sir, for the past 6 months actually. And he has also a normal development, perinatal history and neonatal history. Everything was normal. Normal birth history, no family history. Again, MRI brain done was normal in this patient. So this is the video of this child.
Slow motion video.
Child appears a bit confused after the head drop also, sir.
Any regression of milestones, cognition?
No, sir, no regression actually, but they notice a difference in the behavior. Aggressive behavior was there because he's a small child, sir. We are not able to test school performance or cognition, sir. This is the EEG of the patient taken, sir.
Very periodic, no? This appears to be periodic.
Yeah,
No, sir, it was-
it appears to be very periodic.
No, sir, it was not
Yeah,
actually
okay.
periodic, sir. It occurs in spurts throughout the course of the record,
4
actually.
seconds.
Go further, you see its periodicity.
Yeah, definite periodicity.
There's something
Very normal
reasonable
background
amount.
rhythm.
It's again a case 3, sir, who presented with head drops and nocturnal seizures, sir. We are not able to record the video of this patient actually. Previously had nocturnal seizures, again DRE-like presentation, facial upper limb clonic movements for more than a year. She presented with head drops of 10 per day without loss of consciousness. Again, the child was doing good, sir. No significant birth history. Development mentation was normal. School performance was decreased in the last 5 months, according to the mother. When repeatedly asked for, she was telling this, sir, actually. And MRI brain was done. And this is the EEG of this child. I'll stop here for discussion, sir.
Okay. What was your working diagnosis?
Sir, can I put it later, sir?
Why?
Yes, sir. My working diagnosis was previously a benign Rolandic epilepsy, sir. Now it is actually looking like a myoclonic epilepsy. I thought it could be like a deuce, sir. Because mentation being normal, Lennox Gestalt went low down in the list, sir. I didn't think of SSP in this patient, sir. Since the cognition was normal, with the myoclonus or atonic seizures alone with a negative myoclonus, rather, I didn't think of SSP, sir. Honestly speaking, I didn't think of.
Which case are you talking about?
Sir, all the 3, sir.
I mean, I think you getting a measles antibody in all of these will be worth it, I think. Because if you do, I don't know how frequent SSP is in your part of Tinnevelly. I don't know. You don't see them, it has gone. Has it gone there also?
No, sir. We rarely see, sir. We frequently
then
don't
I think
see.
You get a measles antibody titer in all of these patients. Natarajan?
Sir, except that it was periodic in the second and third case at least, the discharges, but not the classical rhabdomyolysis.
No, it is not. But Natarajan, we have seen non-classical things like this later on becoming classical.
But what would be the differential diagnosis, sir? Why should we be only on SSP? Why not have some differential diagnosis?
Oh, fine, good.
Madam, can I come in, sir?
Yes, sir.
Yes.
Vijayan, sir. Madam, did you do a sleep EEG recording?
Yes, sir. We did a sleep EEG recording, and the burst increases
during sleep, madam.
The
and
burst
did you get
increased.
CSWS?
The burst increased. CSWS was noticed in one patient, sir.
Okay, so this is then, if CSWS is noticed, then probably this is atypical BECT.
Yes, sir.
Atypical what?
Benign epilepsy, benign central temporal epilepsy, atypical form. CSWS is classically recorded in this, and usually they present with what, as Dr. Radha had initially said, focal seizures, and then later on this drops. We
they are
had
not
few cases
benign
like
as
that.
thought.
No more benign, sir, as per conflict.
Yeah, no more benign.
Yes,
Yeah, agreed. No more benign, but atypical, yeah, agreed. And it
How about
responds
the
well to steroids.
Treatment also,
ACTH.
sir. Yes, sir. I will come to that, sir.
How about the drop attacks? How are they related to BREC?
Sir, actually, what they explain is that, no, sir, if they commit spurts actually continuously throughout, they can have these drop attacks, sir.
Is it that it still is a focal form of epilepsy?
Yes, sir. Focal form. But if the frontocentral temporal discharges repeatedly comes, no, sir. Throughout the record, it is there actually, and the patient's continuous record also showed the same. If it is throughout continuous, they can have these drop attacks. It seems, sir.
Is the drops because of spread to the central area?
Yes, sir.
Without loss of consciousness.
Yes, sir.
Professor Zahir will have to comment on that, and Professor GA will have to comment on that.
You see, my first impression was when I saw a clump of cases with continued drop attacks, various kinds of these things, we should be considering SSP, cervical sclerosing panencephalitis. There's one thing which bothers me in a diagnosis of cervical sclerosing panencephalitis. You know, spontaneous, the periodic attack, the whole arms get flung out sometime or other. You understand what I mean? The drop attacks are not that frequent in cervical sclerosing panencephalitis. Not that they can't occur, but they can occur. The other this thing will be benign. These are all epileptic this thing which need to be treated. That's it.
Oh, so GA, sir?
GA, what do you feel?
Can I give you a note in history?
Sir, all the 3 children were doing good, sir. Developmentally normal child, sir, presented
I want
with
to
drop
give you
attacks.
I want to give you all a note in history. In Institute of Neurology, when we are doing a lot of stereotaxy, one of these cases, the question was raised, where are the discharges arising? In the Zahir put an electrode,
Sir,
Can you hear
are
me?
mute. Yes, sir.
Can you hear me?
Yes.
Okay. So we put a cortical electrode recorded from the cortex, from the ventricle, from the upper brain stem, and we didn't find the discharges reversing anywhere. Then we had the choice of putting the electrode down the brain stem, but we stopped for reasons other than science. So a good study was done. This SSCP was a epidemic in 60s when there were no measles vaccine. We had a lot of cases in the institute. As Zahid said, the moment you look at them, that's the first disease comes to your mind, clinically. Thank you.
Can I proceed, sir?
Yes, please.
Hello.
Yes, proceed, madam.
See, I just want to make one more point. We all think that SSP should come to you as a periodic complex disease. And, you know, periodic complexes, periodic falls, periodic. Not necessarily. Not necessarily. You must remember when SSP comes to you, it is an encephalitic process. The whole brain is involved. So it can present to you in any way, but ultimately you will get periodic complexes and classical this one. I'm not saying this is it, but this is what goes through my mind. Yes, Natarajan.
Sir, one thing, the last EEG which madam showed was very classical Rolandic epilepsy EEG. So with this history,
I'm not saying no. As a matter of fact,
with this EEG, if sleep recording shows CSWS, then this is atypical BECPs.
So differential diagnosis thought of was DOOS syndrome, Lennox-Gastaut, and atypical benign Rolandic epilepsy syndrome. So, DOOS syndrome, the patient child usually presents between 7 months and 6 years of age. Seizures generally consist of generalized myoclonic, aesthetic, myoclonic epilepsies, and short absences. Mostly generalized tonic-clonic seizures also comes, but these children lack that actually. And development before onset also will be normal. There will be a mild regression in cognition, and these patients also sometimes go a remission at the age of 10 years. The second one is the Lennox-Gastaut syndrome, that a patient can have a typical drop attacks like, but here it will be associated with the classic tonic seizures, and also they can have other types of seizures as well. And the development will be retarded in these children. There is a differentiating point between these. And the third one is the atypical benign Rolandic epilepsy, or it's again called as a pseudo-Lennox syndrome because of the repeated drop attacks the patients have. Here, the age of onset will be 3 to 12 years of age. Atonic seizures are the most characteristic feature here. In addition, the patient can have a partial and generalized motor seizures also. Developmentally, these patients will be normal and they can be slightly retarded. Detailed cognitive examination can show changes in these children, and disappearance of these seizures during adolescence or even prior to that is the rule in these patients actually, and they respond very well to treatment as well. So this is a table which shows the difference between the typical and atypical benign Rolandic epilepsy or BECPS. Seizure semiology in typical one will be brief, partial seizures, facial motor seizures, and here it will be an atonic seizures involving the extremities also. Seizure frequency and duration, here it is infrequent, commonly occurs during sleep, whereas it occurs during major part of the day and increases sometimes during sleep also. Cognition and language, major changes in cognition have not been classically associated with the benign DRE, whereas here it is associated with behavioral disturbances like attention deficit hyperactivity disorder, language dysfunction, cognitive dysfunction also. Treatment is that focal epilepsy treatment, depending on whether it's a European school of thought or American school of thought, both can be used actually for BECTS. Both oxcarbazepine and valproate can be used. Both proved to be of use in benign Rolandic epilepsy. Whereas here the carbamazepine and benzodiazepines has to be avoided, which will aggravate the clinical symptoms or the drop attacks. So here the broad spectrum AEDs like valproate is usually chosen. Immunomodulation is not required in typical BRE, whereas it helps definitely in atypical atonic BTCS. And imaging is normal in both, and tendency to relapse is not there in typical BRE, whereas it is there here. And EEG is very classical. Unilateral centrotemporal spikes will there, and market activation in sleep also can be there in BRE, whereas here it will be throughout the record, and as Vijayan sir said, there will be CSWS in sleep. That is the hallmark of this. So this is the atonic variant of benign Rolandic epilepsy. I learned this term from Dr. Ashalata madam from Sri Chitra when I referred my first case actually. So she gave me the diagnosis of this, and she also taught me how to treat this actually with the monthly course of methylprednisolone, and the children are doing well, sir, actually with the pulse, initially a pulse treatment for 5 days with methylprednisolone, and the child is put on valproate. So most of the child are responding very well, sir, actually. I have totally 5 cases till now date. So this is the treatment. Carbamazepine was started on sodium valproate, and levetiracetam is given in the textbooks, but we don't start because sometimes it can aggravate the behavioral effects which is seen. When the patient doesn't have improvement after 7 days of starting valproate, the patient was given a methylprednisolone also. And atonic episodes were decreased, and truncal swaying while walking also decreased in these patients. So this is the repeat video of this child.
What happened to EEG?
Sir, sir, I was not sir, I was not able to get the post-treatment EEG, sir.
Don't worry, don't worry. Can you make a small write-up and post it?
Yes, sir, we'll do, sir, definitely. So this is the second child, sir, after treatment.
On MIN website?
Yes, sir, I'll do, sir.
What you just did critically will be wonderful, yeah. Congratulations. Beautiful. Yes, President, sir. Zahir, final comments?
Yeah. No, I have no comment. I mean, you see, we are all old, this thing, so experience dictates us, you see. So I think, as I said, first thought, my thought was that when the child had this thing to exclude subacute sclerosing parencephalitis. But I am familiar with Rolandic epilepsy being treated this way. Natarajan?
No, sir, I have no comments. Radha madam, what did Ashalata have to comment?
No, sir, she only gave me the first diagnosis. They have written a write-up also, sir. I'll show that write-up, sir. It's done in, actually, the study was done in Sri Chitra. They have collected patients like this.
Yeah, this is what Professor GA wanted.
Can you post the reference, please?
Yes, sir.
Please. Thank you so much.
Thank you very
Excellent
much.
learning day.
Thank
Yes,
you very,
sir.
very much, all of you. Natarajan,
thank you,
thank you
sir.
for giving me this opportunity.
Sir, thank you, sir.
Salute to all of you.
Thank you,
to all
Dr.
of
Thank you,
you.
Natarajan.
Dr.
Thank
G.A.,
Thank
thank
you,
you for
Zahir.
joining.
Thank you, sir.
Hi, Lakshmi.
Zahir,
Thank you
Biswakumar.
very much. Lakshmi, thank you.
Thank you,
Thank you.
Radha.
Thank
Thank
you,
you,
sir.
BVK, sir. is there.
Radha,
Thank-
thank you.
Thank you, sir.
God bless.
Natarajan.
God
Be
bless
safe.
you all.
All of you be safe.
Yes.
Big thanks to Sun Pharma
with my
for
past
putting
history,
this
you
on.
must be safe.
And thank
Thank
you,
you very
Saravanan,
much.
and thank you, Radha.
Thank you, sir.
Thank
Thank you,
you.
Thank
Natarajan.
all
Thanks for the
participants,
opportunity, sir.
Vijay and Vikas,
Giving.
Bhupti, sir. BBK sir, thank all of you.
Thank you.
Thank you, sir.
Thank you.
Vijay, thank you, Vijay.
Thank you, sir. Thank you, sir. Thank you very much.
Is Vikash there still?
Eh? Padma?
No, no, sir. I'm just asking. Vikash, are you there still?
No, he,
Okay. No, he is an epileptologist who had training at Sri Chitra, sir. So I wanted to ask.
he's left.
Because sir, it's left, sir.
Okay,
Sir
okay.
is-
Thank you. Thank you. Thank you.
Thank you, Natarajan. I'm going to
Thank you,
discontinue
sir.
now.
Thank you,
Thank
sir.
you. God bless.
Thank you.
God bless.
Thank you so much, sir. Thank you. Thank you.
That's it.
Thank all of you, madam.
Thank you, sir. Thanks a lot.
Great cases, both
Thank you,
you
sir.
and Saravanan. Thank you, sir. Thank you, Habib. Ibrahim, sir, are you closing it?
Okay, sir.
Thank you. Thank you so much.